Hello. What's up, YouTube? It's Roy L here. Hope you guys are doing well. Um, I'm sure you guys already know. Based on the title, I'm here to talk my sugar. Got my notes in front of me and everything. I don't even know what today is. Today is October 8th, and all this has been happening in the lifespan of just a couple of days, like 3 or 4 days for since up till now. But yeah, we have nurses trying to be respiratory therapists. I didn't know they could do that. But anyway, speaking on it, I normally don't have the ICU. Last month I had the ER the whole month. I don't care what anybody says. I've had ER duty all month. So I'm actually kind of tired of ER. So it was kind of different getting the ICU. But anyway, when you go into your shift and you go see who works there and who's doing the shift change, who's going to be working your nights, your nurses, that's how you know if it's going to be a good night or a bad night. And I saw one of the nurses who, I'm cool with her, but she's always on nerves when something's just not right. But there were two patients up there. She had to manage, nothing too crazy. One was what was it, a transport patient. I don't recall what was wrong with them, like diagnose wise. And then the other lady was something serious. She had like what, lung cancer and dementia. And her dementia was like mild to moderate levels, and she was a DNR. But speaking on the other patient, he was dark skinned, and his pulse ox was reading like 74, something like that. But prior to that, she, calls the respiratory emergency cell phone, and you can hear her panicking over the phone, and she's almost, Royale, patient satin, 74%. It's a good waveform. I don't know what's going on. I'm like, okay, well, let me just go up there. So I go up there, whatever. I enter the room. The patient's just sitting there, comfortable, just looking around, just ready to get on with his life. Really, that's what he looked like. He just wanted to go. And I go in there. The nurse is in there. She's like, "Oh, thank God you're here, Royal. He's sat in like 74%. You think you should get an ABG?" And I'm like, look at the pleth. Look at the waveform. It's not even symmetrical. There's no type of correlating tracing. Everything's like all scrabbled and not really necessarily aligned. And she went ahead and tried to call the hospitalist, and then the hospitalist called me. I'm like, no, I'm not getting no blood gas on the guy who's fine. And I even asked the patient, like, you have to assess your patient whenever you're in these situations. Homeboy had no accessory muscle use. His breathing was normal. He was breathing like 18 breaths per minute. Heart rate was good and everything. But I feel like some of the nurses, or maybe they do, or maybe they just forget because of their nerves. But, darker people, obviously darker than me, they have a hard time. Our pulse oximetry in general is just harder to get on people who are have like darker not melanin. So it's just like you have to just, like I say, assess your patient and everything. I know that patient was like a smoker and everything, but if he's over here talking to you, answering all your questions correctly, then what are you worried about? Why do you want me to stab this man for no reason and then get him transferred out to, like, there's no reason to do that. And, EMS came by or whatever, getting ready to transport him away. And, the nurse is still freaking out. He's on 5 liters, blah, blah, blah. I'm like, you can turn that down to 2. I even did it, but she went ahead and went behind my back and turned it back up. I was like, I ain't gonna fight you on it. And the EMS lady was like, Royale, you think I should keep him on 5 liters? Like, I'm like, no, you can turn him down to 2. It's fine. There's nothing wrong with him. You can just really look at him and make the assessment of what type of oxygen flow you want to put him on. And the EMS lady turned to me and she goes, you know what, Royale? I trust your judgment. And you know what? The dude was fine. He's fine. He left happily. Ain't nothing wrong with him. And then I think after that scenario, me and that nurse, things just like the atmosphere changed. And what I mean by that, it's like she didn't want to talk to, and I don't care. Um, it's like she didn't want to talk to me. She didn't want to like get my help for anything. And this is leading up to her other patient. So now she's only up to one patient to look after throughout the night. And like I said before, this patient had lung cancer, um, history of dementia, and the levels of the dementia were mild to moderate. So there's a bunch of respiratory equipment in the room. Not a bunch, but there was two. A BiPAP and a high flow nasal cannula. And the patient was a DNR, and I understand the patient was having dementia and anxiety and whatever the case may be that would make her, not really settle in her bed and just go to sleep. But for some reason throughout the night, that patient kept, and I put her on the BiPAP because that was best for her, not the high flow, because she was mouth breathing and she was just repping off that cannula left to right. So the mask, it just worked for her. And the settings I put her on were like minimal, or someone else, not me. I just threw the BiPAP on, but the settings that she was on was like 14 over 7, rate of 18 and 100%. And she was resting comfortably. She's getting good tidal volumes. But throughout the night, she kept hitting that call button, calling for the nurse and everything. And, this is the same nurse that don't want to talk to me. She just over here. Now, I'm still in the ICU just looking to, make sure everything's good or whatever. And for some reason, I guess the nurse thought she was having, or maybe she was. I wasn't necessarily looking at the patient as I should. I was really looking at her because she started to touch my equipment, the respiratory equipment. Because like I said, I don't know why nurses are trying to be respiratory therapists, but for some reason, this particular nurse wanted to give, I guess she gave the patient Ativan compared to Precedex. I don't know, whatever. But she was giving her some type of oral medication to calm her down or whatever. And I'm watching her. She literally took off the patient's BiPAP for no reason. I mean, not like completely, and tried to transition to the high flow nasal cannula just to give her the medication. And I'm at the desk area, and I go, "Why did you transition from a BiPAP to the high flow if you know she's gonna fight that high flow?" And she goes, "Because I need to give the patient medication." I was like, "You can just put the BiPAP on standby and, lift up the mask, let her put the medicine in her mouth, let her take sips of water, and then put it back and swallow it, and then, put the mask back on." And not to mention, I was watching her. There's a whole camera in the room, so I wasn't going to be liable if something was going to happen. But, whenever she decided to try to put the high flow on, I told her it's not even on, so I don't know why you're doing that. And she goes, "Why didn't you tell me?" I didn't want to be smart right there. I could have. But, some things are just better left unsaid. I was going to say, well, you're not the respiratory therapist, so you didn't want to touch it. But, I don't know. And for some reason, she kept trying to, try to explain why she did what she did. But I told her after everything was said and done, after the patient finally settled down, I pulled her to the side because, like I said, I didn't want to. I'm the type of person, like, I'll educate you on something, but I don't want to make you feel embarrassed. So I pulled that nurse aside, and I was like, how'd I do it? I was like, "So I don't want you to think I'm targeting you." Whatever. I was like, "I don't want you to think I'm targeting you, but." There was necessarily no reason for you to go from, the BiPAP to the high flow, back to the BiPAP just to give medication. And I was explaining to her, if I feel the need, as if I can trust you to put this equipment on without me being here, then that can be the case one day. But for now, I told her, if you ever, like, she normally does contact me if it's any type of respiratory equipment, but it's like, for that particular patient, I don't know, she was just all over the place. She was bouncing off the walls, just huffing and puffing, and I'm just like, just listen. Let me be a respiratory therapist. You be a nurse, let me be a respiratory therapist. If I think a patient needs a blood gas, I'll get it. You don't gotta contact the hospitalist. I'll just get it and run the blood myself. We got a little ABG machine to where we run our own gases, because sometimes when we send blood to the lab, it somehow gets solidified or somehow lost, and you're just like, man, I don't even want to deal with it. But yeah, it's just like, and if there are any nurses watching my channel, I appreciate you guys for watching. I appreciate you nurses for all you do. Don't think I'm talking bad about you guys. It's just, if you know what you're doing respiratory wise, even though you're not a respiratory therapist, then yeah, I trust you. If you could put a BiPAP on, yeah, go for it. Some BiPAPs you gotta hit the button to turn them on, and others you gotta just put it over their face and they'll sense a flow and they'll activate. But if you got a patient who's a DNR, lung cancer, and dementia, just leave her on the BiPAP. It's better for her. It was better for her well-being and everything. And the funny thing about that patient, even though they were a DNR, this goes back to one of my other videos where I say there's not necessarily family education when it comes to these people's lives. But it's like, patient was a DNR. The next day I come back, they're intubated. I'm like, why? How did this even get like this? And they were talking about how, there was a family member who wanted to reverse the code status. And I'm not trying to be heartless. I don't want you guys to think I'm like that type of person. But it's like, the lady wasn't even satting good to begin with while even on the BiPAP. 14/7, 100%, getting great tidal volumes and everything. From what I recall, her sats were like 88 on 100%, and lung cancer. I mean, that's really the best you can do. You can't live on BiPAP forever. So I don't know what doctor or whoever didn't want to just educate the patient family member, or whoever made the decision to even do that. That's why hospitals, we do the best we can to help people. I don't want you to think hospitals are evil, but it's just like, it's a business, and it's sad, and sometimes it's good depending on the scenario. But whenever you have patients who have lung cancer, and they put a whole tube down your throat, and then when you take it off, it's going to go back to the same problem you have in that lung cancer. Same thing with the dementia. The lady, that patient was like in her late 70s. So I mean, she practically lived majority of her life. But like I said, it's just, you just got to educate people, whether it's a nurse, whether it's a family member. We have to do it. We can't just constantly put people on ventilators and they're at the end of their life. Like, I've seen, and this is why I'm taking a break soon from my jobs. I'm going on like a 4-week, or not 4-week, I wish, a 2-week vacation just away from respiratory, because I'm tired of taking care of people. Like, it gets exhausting whenever you have a patient who can't clear their throat. They act like they can't do it, but they can. And then they aspirate, and it's just like, it's just foolishness. But, speaking on education, the other day too, I had a cardiac arrest. I went to it by myself because, I'm a big boy. I can do that. But this patient came in with cardiac arrest. They were down for like 15 minutes. But we got a pulse back and everything. Tube placement was good. Well, prior, because I thought it was too deep. So I ended up pulling the tube back to like what? 26 centimeters at the gums. Had the vent setting set up how I know, because I'm good like that. I'm a RRT. I can make it clinical decisions. But my particular coworker on that day, I'm not gonna say any names or whatever location this is at, but I told them they had a coming up, because like I said, I don't normally get the ICU. I always have the ER. Primarily, I think the reason why that is because I just don't arrive early to just go and pick assignments. But where was I going? So anyway, that patient, got the tube placement going, everything, the settings were good and everything. I'm giving a report to my coworker, respiratory therapist, who's with me. And that coworker, I was telling her the settings and what I did. And the coworker, she made a comment about what I did with the FiO2, which is the oxygen. So originally I had his settings on tidal volume of 420. His respiratory rate was 24. I time was like 0.85. And some of you may not even know what the hell I'm talking about, but just listen. Had the FiO2 originally at 100%, but I turned that down to 40 and a PEEP of 5. Now prior, got a blood gas. He was very acidic. His CO2 was like 73, 76, top of my head. And his pH was obviously acidic as well. So, got a blood gas later, which was like what? 5? Well, it was on her assignment now, because I just transferred that patient to go upstairs to the ICU. And she was saying, oh, prior to that patient going upstairs, I'm telling her the settings, and she was saying how I went too aggressively on the FiO2 from 100 to 40%. Well, if you look at the blood gas, the PO2, I wrote it down actually, but the blood gas was like 7 point, let me see, because I wanted to make a video about this like a couple days ago. I've just been, okay, so anyway, the first blood gas I got on that guy was at 1117, right? His pH was 7.23. His CO2 was 73. His PaO2, that's his oxygen, this is on 100%, is 410, and his bicarb was 22. And the settings I did that we left him all night until for the next blood gas was 420, rate of 24, PEEP of 5, and 40%, because I turned it down to 40%. And the respiratory therapist goes, well, that's too aggressive. You shouldn't have done that. So I ignore it. I'm not gonna comment on something where I think that's up to my clinical expertise, because, and I'm not comparing credentials. That respiratory therapist has been in the game longer than me. I've been in the game for 2 years, but I feel like I can make a clinical decision on how to manipulate a ventilator, because I've took multiple tests. got plenty of experience during COVID to understand how ventilators work, BiPAPs, high flows, everything. So anyway, the routine blood gas was done on my settings at 5:02. Listen, listen now. Beautiful blood gas, literally. pH was 7.36. That's in the normal range of 7.35 to 7.45. CO2 is a little high, just by 3, but it's a 48.5. But that pH is compensated. And this is still on 40%. Everything else is the same. The PaO2 was 191, and the bicarb is 27.5. So like 1.5 off. But that blood gas is compensated. I did that all by myself. No doctor, no nurses, no extra side respiratory therapists telling me how to manipulate a ventilator. If you are confident enough to make your own decisions, make them. If you know how to save a patient's life by, having an idea, or by simply just doing something with the ventilator, do it. Don't let, an older respiratory therapist, like I said, they're experienced. They have way more experience than me. But me not being cocky or anything, I'm humble enough to say if I need help with something, I'll ask for it. But the guy's fine. He's chilling. Blood's good. Everything's going good. He's getting his medicine. He's getting treatments and everything. I didn't want to make this like a sob story video. Not a sob story, or just like a drama video, but it's more like, I think everyone just thinks I'm not capable, or if I'm crazy, that I can't make these decisions on my own. And like I said, even though I've been in the game for 2 years, I could run circles around even some of the older respiratory therapists. Not all of them, but I sure try to learn and understand tricks along the way to make the decisions that I make. But whether it's a nurse or if it's a respiratory therapist, if you're confident enough, just do it. Get cool with the doctors. Get cool with, some of the nurses. Some of the nurses, I was actually teaching one of the travel nurses. I don't really talk to her much, but I remember the other day with that patient I was just talking about, she was in there coding that dude with us. And, after we got the patient's pulse back and everything, and blood pressure increased and whatever, she was staring at the ventilator. I was like, "You need help trying to figure out what you're looking at?" She's like, "Yeah, I gotta tell the doctor, what you did, and eventually tell the ICU how you did things." And I was like, "Okay, cool, I'll tell you. So this is the tidal volume, this is the PEEP, this is the FiO2, just easy stuff." So this is mainly, I think I made this video just mainly to be a message for anybody who thinks they can't do something, particularly medical field related. For me, it just happened to be respiratory. But you're in charge, You're taking care of people's lives, whether if they're sick, and if they're 99 mimas full code, then, so be it. But I mean, you do what you can. Don't get discouraged if another respiratory therapist or a nurse or even a doctor says elsewise in the things that you've done, especially if you're knowledgeable. especially if you were one of the top respiratory therapists in your class. Anyway, I'll see you guys in the next one. Very excited for my vacation. I don't think I'm gonna be posting any videos during my little vacation. Like I said, I just want to get away from social media and just kind of get my mind in place for the weeks to come. So that's exciting. So with that being said, I'll see you guys in the next one. Bye bye.